Dr. Jamie Koufman, and this is Dr. Koufman's Reflux Hour. Today's topic will be reflux treatments. But before I begin, I'd like to point out that many of the questions, in fact, most of the questions asked in the question section today the answers are found in my blog. So if you are part of this group, this Facebook group, go to jamiekoufman.com and sign up for the blog. And each week you'll get an email telling you the topic, and if you're interested, you'll open it. If you're not interested, you won't. It's interesting because all of the topics written since the first of the year apply to most people, so there's a lot of consolidation of information. For example, the detox diet is in January. I'm supposed to talk about reflux treatments, but I will tell you that if your ship is sinking, having a bucket to bail is hardly going to solve the problem. So if you're having trouble breathing and you're waking up in the middle of the night coughing and you have postnasal drip and shortness of breath and 15 other symptoms of new term respiratory reflux, better than LPR, respiratory reflux, then which medicine is best for you is not really an important question. You're going to need a very comprehensive program that's designed to stop the reflux for long enough that things might heal. I will tell you that most people are in the category that they need to have a reflux detox, and the detox is quite intense, eating really, really early, sleeping on an incline, and we'll talk about some of the medicines here in a moment. But diet has to be low fat, low acid, nothing out of a bottle or a can except water and tea and coffee, preferably alkaline water, and so on. So if you're having a lot of symptoms, asking, is this particular medicine going to help you more than another one, is almost irrelevant. That said, I'd like to talk about medicines. So the first category of medicines are antacids, and Mylanta, Maalox, Tums, and Rolaids are the four that you'll find in every pharmacy, and they're predominantly for people with esophageal reflux or GERD. So they're not for people who have respiratory reflux. They don't help you at all. So if you're having heartburn and indigestion, you can get those medications and use them on an as-needed basis. I will tell you, a long time ago someone came and said, when I chew gum, my heartburn goes away. And so we did a study on gum chewing, and what we found is that when you chew gum, you make more saliva, more salivary bicarbonate, and you swallow a lot more. And so you actually push the reflux down, and we did show reflux events could be avoided by gum chewing. And the same is true for hard candies. We put Ricola for free for people to take in Carnegie Hall. It's this Ricola, big old-fashioned square ones. And a lot of the noise went away. All those people went out to dinner, they had cocktails, they want to clear their throat and cough, and when they suck on a hard candy, they don't. So that's one of the things, one of the options, one of the treatments that's probably not on your list of which medications. After antacids comes H2 antagonists. Histamine 2 receptors are in the stomach, as well as proton pump receptors, proton pumps, and the H2 antagonists attack the histamine receptors, and the proton pump inhibitors attack the proton pumps. The proton pump inhibitors are actually stronger acid suppressors, but they have so many side effects and so many worries associated with them that actually I stopped using proton pump inhibitors in 2014. And that's when the Danish study was published, which said long-term use of PPIs is associated with an increased risk of esophageal cancer, increased risk. And the reason is because it stops the symptom, particularly for the heartburn sufferer, but the disease goes on and marches on unabated. And so the answer to the question is, how good are PPIs in treating reflux? The answer is they cure 0% of people. They may help symptoms, but they cured 0% of people. So I'm not going to talk about them in general. They're all the same as far as I'm concerned. I don't see much difference between pantoprazole and omeprazole, although there's some evidence that some of them are better than others. The H2 antagonists are very interesting. We went for a long time after 2014 recommending ranitidine, which is Zantac, and it was taken off the market because of a question of a contamination with a carcinogen. It's interesting, I've just put up an article yesterday on famotidine, which is Pepsid, and if you'll notice in that list of references is a massive, multi-institutional, multinational study that shows no relationship between cancer and ranitidine use. So, you could argue maybe a competitor found out, maybe it was a PPI manufacturer that was worried about competition, who knows. But as a result, the next line, or the next in line, H2 antagonist is famotidine. And I've been asked questions over and over and over and over about the safety of famotidine. I think that this particular topic specifically tells you why there is no such thing as good information on, if it can't be validated. There's no such thing. You can validate me. You can look at my curriculum vitae. You can look at my publications. You can look at my books. But information on the internet is basically terrible. So what happens is, this is the old way it happens. You tell a story to your sister, and your sister tells her friend, and her friend puts it on Facebook, and the Facebook friend decides to put it on a different version for their cousin, and by the time you hear the story come round, it's not the same story at all. So a major publication found all the symptoms that people said they might have, and listed them, and then asked some Creighton pharmacological group to okay the article. And the answer is, of the 25 or 26 symptoms listed, 23 of them are bogus. So first of all, this drug's been studied a lot. If you want to find out information, you go to PubMed. It's peer-reviewed articles, okay? So I went to PubMed and I looked at the side effects. So if you look at, for example, famotidine and hair loss, famotidine and skin problems, famotidine and seizures, no data anywhere. Okay, not even a case report. So what I found actually is the most common side effect of famotidine isn't even listed. And remember, I've been treating people, maybe thousands of people with famotidine over the years, including pregnant women with little fetuses. And the most common side effect is actually dry mouth. But it doesn't occur with famotidine alone. It's usually a combination of famotidine with someone who's also taking an antihistamine for allergies with another drying medicine. It usually takes 3 medicines, with famotidine being the last one to cause dry mouth. I've had everything. Since I wrote this article, I have a person who wrote me and said that it causes hair loss. I went and looked at the literature. In fact, even the literature on the internet says it doesn't cause hair loss. There's not a shred of evidence that it causes hair loss. And the other one was interesting, was tinnitus. But the person who had tinnitus also said they got tinnitus with the PPIs. They're not even closely related drugs. And so I got one from Mexico that said if you take famotidine, you can't tolerate jalapenos. So all I'm saying to you is people have a lot of symptoms. There are a lot of, what do we call it, coincidences. They could be coincidences. But the data needs to be data. And for it to be propagated from one person to the other, there ought to be science behind it. If you don't believe in science, then you should turn off this Facebook Live. I believe in science. So I found out something I didn't know. Famotidine is the safest of all. It has least drug interactions, which are always a factor potentially. Computers are supposed to pick that up now. I don't know of any drug interactions with famotidine. But what I found out is it's 7 times more potent as an acid reducer than was ranitidine, which is off the market since 2020, and it's 20 times more potent than cimetidine, its cousin, that's on the market as Tagamet. So famotidine is gold. It is our best 20 milligrams or 40 milligram of famotidine before bed is valuable in the treatment of reflux. Now, let's get back to this question. The idea of, I have questions here where people are asking me, I can keep my reflux under control if I do this, or I do this every other week. That's not reflux control, okay? That's like saying, I can fix some of the holes in this boat so it doesn't sink, and I go in and bail a lot, and then the next week I can enjoy myself, and the next week I got to bail a lot. So the answer is that reflux is a sort of a sine wave, and what happens is you have it all the time, but something comes along that makes it worse. A bad night out, too much drinking, maybe an upper respiratory infection, COVID, whatever. So a lot of things can tip you over. But the idea, at least my idea, is to get rid of the reflux, and to do so, you need to absolutely terminate it 100% for a period of weeks. And that requires very intense program. Now, the big question comes with all the other, and it's going to be answered in a minute in the question section, but a lot of tremendous misinformation is propagated by your gastroenterologist. The gastroenterologist stuck their head in the sand when I started publishing about laryngopharyngeal reflux or respiratory reflux in the 80s. Every one of the opinion leaders in GI know me. I know them all, or used to know them all, and they don't know anything about respiratory reflux. So having a test like a Bravo test is useless. Having impedance pH tests for respiratory reflux is useless. Asking their opinion how to treat it is useless. The problem is that the GI is the go-to doctor for reflux. It's not in the ENT curriculum. Some of them know some about it, some don't. It's not in the pulmonology, the lung doctor curriculum. It's not in the allergist curriculum. So, you are the doctor, and you are going to have to educate yourself. And I think that we'll finish with talking about these medications, and then I'd like to answer some questions that basically tie these two things together. So after the proton pump inhibitors, the newest group is potassium competitive acid blockers. And I've delved into PubMed, the medical literature, the peer-reviewed medical scientific literature, meaning you wrote the paper and other people who you didn't know judged the paper on its merits as a scientific article and so on. So there's not enough data on this. There's original data that it causes liver injury and liver problems, and there are other side effects. So we don't really know enough about these that I wouldn't recommend potassium competitive acid blockers. Next comes sucralfate. Sucralfate basically is a drink that coats and protects the esophagus. It's of no use whatsoever in respiratory reflux. So if you get heartburn, indigestion, and esophageal reflux, sucralfate may help, but it's a prescription from your doctor. Finally, I'd like to talk about motility drugs. So people are asking me, shall I have motility studies done? Meaning, does my esophagus work? And the answer is, a vast majority of people who have had reflux for more than a year or two have motility disorder, meaning the normal peristalsis, taking a swallow from top to bottom into the stomach, is not what happens. There's some breaking up of that from time to time. Reflux causes that. The most common cause of dysmotility is reflux. So I had a person who had absolute aperistalsis. That means dead tube, nothing moving, with manometry, and back to absolutely flat normal within 6 months of reflux treatment. So understand that dysmotility is most often caused by reflux, and motility drugs are not the way to go. Eradicating the reflux is the way to go. I want to talk a little about enzyme. I do have a conflict of interest. I'm the medical director, and I'm also a shareholder in Enzyme Biomedical. We're using fosmanprevir, which is actually a safe drug that's been around for a long time for the treatment of a new variation of it, for a spray and a pill. And again, I think this is going to be very, very helpful, particularly for people with throat issues. If you're doing 8 shows a week on Broadway, this is great. It's ironic that these little blue bottles, which I recommend, if you read my most recent article, just click on the blog, Alkaline Water, you'll see these little blue bottles. And the reason why these are important is when you swallow alkaline water, you don't get any on your vocal cords. They clamp shut as like a fist, so you don't aspirate. Meanwhile, if you open your mouth and spray, pH 9.5, same water I drink, pepsin dies at pH 8. This is the only thing you can do to wash it out. It's interesting, this has sort of become a fad on Broadway. I haven't treated everyone on Broadway, but it's sort of gone by word of mouth. I actually saw a person spraying with one of these bottles on the L train in New York. So read the article. This is very useful adjunctive treatment. Is alkaline water and alkaline water spray. And if you're having nasal congestion and nasal problems, the same company that makes these, you click on them, it makes nasal dropper, and you could get up in the morning and put it in, and then wait a couple of minutes, and I'll tell you, there's a very interesting sign. If you put alkaline water in your nose and it burns, you've got terrible reflux, and that burning's going to go away. So we've talked about pretty much all the ones I want to talk about. I want to reiterate that chewing gum and sucking on a hard candy after you eat is a very inexpensive way to go to give you some benefit. And I personally like the Ricola for if you're going to suck on something. And I like sugarless cinnamon gum, no mint. The flavor lasts longer than like juicy fruit and other things like that. The last thing I want to talk about are the alginates. Alginates have been around for a long time. There are a whole slew of new products. A Gaviscon Advance, Aniseed, 500 ml bottles. I've written a blog on alginates. It's got a really pretty picture of seaweed, and it's an interesting article. But alginates, still the gold standard is Gaviscon Advance. Aniseed, the liquid, it's drink it out of the bottle after dinner and before bed. And if you're having symptoms after meals. By the way, also take it before you exercise and chew gum or suck on a hard candy while you exercise. And there's an article on exercise and reflux. So that's pretty much what I have to say about drugs and treatments. The only treatment that works is to change your diet and lifestyle enough so you don't have reflux anymore. I'll tell you an interesting story. I haven't had reflux for years, but I have a bad back, and I like lying down, particularly in the evening if I've been very active. And so I would eat dinner, and then I'd be lying down and start having reflux. So I learned, even though I really, really want to lie down, I can't lie down after dinner. And so that's a very simple solution for me. It doesn't require a big treatment program. I recognize the problem pretty quickly. So everybody's different. You all have different risk factors. Some of you need to sleep high. Some of you need to eat early. Some of you need a constellation of things. Some of you can't drink alcohol at all, and so on. So the first question here boggles my mind. I have been dealing with asthma, breathing difficulty, burping, feeling like food is coming up, coughing, gagging. Diagnosed with cancer by 2 doctors. Finally, someone said I didn't have cancer. Pulmonologist specialist thought it might be LPR. Changed my diet. I'm on 60. So none of the details are here. Cancer where? 60 milligrams of what? I've had some relief. Recently, I've had 2 gastro tests where I swallowed a little camera. The results were inconclusive. Second test, the tube was in my nose and throat. That was over a month ago. So anyway, all right. So let's start with the beginning. You've got prize-winning respiratory reflux. Okay, if you sleep through the night, you don't have heartburn or indigestion, you have silent reflux. If you don't read any other article, read SNOR, S-N-O-R-R, silent nocturnal respiratory reflux. That's what you all have, and you have symptoms during the day. It's an American way. We eat late, later, it's a big meal, big refueling meal of the day. That's how we entertain as we drink alcohol. So America has silent nocturnal respiratory reflux and sinus disease, but neither the doctor nor the patient know it's reflux. Breathing problems, neither the lung doctor nor the patient know it's reflux, and so on. Remember, the gastroenterologist hijacked reflux. So this patient, or this person, is so all over the place. My primary care doc said I had a hiatal hernia. Read my article on hiatal hernia. It's of no clinical significance, unless it's big. Okay, so this question of this complex question with 15 different parts. Get on my blog, pretend you're a medical student, and if you don't spend an hour or 2 hours a day for the next week or so, you're wasting your time and money seeing all these doctors. Because, in essence, and I say this all the time now, it sounds funny, reflux is not a medical problem. There's no pill or procedure going to make it go away. And if you want to ask me about the links, the magnets, the strata, all that, all those procedures have gone by the wayside. They may help for a little while, but these partial procedures to try to tighten the valve and all the new ones that are coming along are essentially worthless in the long run. And that's been my experience. Got to remember, I've seen tens of thousands of patients like you in my practice over the course of almost 50 years. So, I'm wondering if I can still do my planned surgery under anesthesia, which is approximately 6 hours. Now, I assume, this is another question, by the way. I assume, this is from Sharon, she's having something else, she's having a hysterectomy or her arm fixed or shoulder or something like that. And the answer is, if you have bad reflux and you have an endotracheal tube, a breathing tube during surgery for 6 hours, you do stand some risk of getting some ulceration. And but it's not as common as it used to be, partly because they're using smaller, less traumatic tubes. So I wouldn't cancel your surgery. I'm working hard to heal before then, and I think that's great. Eat early, eat a good diet, and stay away from everything in a bottle or a can. You know my stuff. Next question from Kim. Does Gaviscon decrease bone density like some other acid reflux medicine? Absolutely not. Only proton pump inhibitors are associated with bone density loss. Gaviscon Advance is seaweed. And it'll bring me to a question that comes later on here, which says, let me find it. You recommend Gaviscon Advance Aniseed. It contains one of the ingredients, propyl paraben. I can't even pronounce it. Parabens mimic estrogen and can act as potential hormone endocrine system disruptors. This goes on and on, okay? This medicine has been the most popular reflux remedy in the world for at least 30 years, okay? It's not an endocrine disruptor. Whatever is in it seems to work and nobody gets sick from it. People say sometimes it has this or that in it and they're concerned. So Gaviscon is a non-medicine medicine. It is a seaweed, and it forms a raft when you swallow it, and it floats up to the top of the stomach and helps create a blockade at the lower esophageal sphincter. This comes a very, very, very complicated question. Can the vagus nerve issue be fixed by lifestyle change like you say? And the answer is respiratory reflux can occur as a result of a vagal neuropathy. Okay? I was perfectly healthy and got the flu at age 45 and sick as a dog with the flu. Then I lost my voice. I examined myself. My left vocal cord was paralyzed. Then I started to cough continuously, and I had all the respiratory reflux symptoms. So until I got the virus, I never had a voice problem. I never had a cough problem, reflux problem. So the vagus nerve, if you read my article, there's a 3-part article on the vagus nerve. You'll see that vagus nerve hits occur a lot with viruses. In fact, we did a study that shows 40% of the American population has had a vagal neuropathy or something happened to one or both of the vagus at some time in their life. The answer is absolutely treat your reflux. Don't worry about the vagus. The vagus will take care of itself. People who have vagal symptoms have painful speaking, not just vocal fatigue, okay? They have burning throat, and I don't mean just after eating, burning, okay? And they have neurogenic cough. They cough all day long. It's a dry cough. They don't have any other reflux symptoms. Those are the three neurogenic symptoms that I worry about. So all you people who have postnasal drip and asthma and everything else, don't worry about the vagus. Can I put your water drops in my eyes on a regular basis as my eyes are painful and sting through the night from nocturnal reflux? I don't think your eyes are I don't think reflux causes dry eyes or reflux eye. There's nothing wrong. You can put any water you want in your eye, as long as it's not too acidic. But I would ask the question: do you have Sjogren's syndrome? Do you have some other condition? An eye doctor might be in the water. I don't think it's reflux eye. So this is the big one. It's one of the big ones. I see. This is a question from Alan. I have every symptom you mentioned. Videos, blogs. I was diagnosed with asthma 2 years back when I went to a pulmonologist for breathing issues. This year I got COVID. Doctor prescribed Advair, albuterol, and all that. And so they get a little question: do I have asthma? Do I have reflux? Do I have both? So let me make this clear. If I don't teach anybody anything, it's this. If you have trouble, and I say it to patients, when you have an asthma attack, do you have more trouble breathing in or out? In, you don't have asthma. So, physiology, don't have asthma. Okay? Breathing in, noise breathing in, that kind of wheezing, not asthma. When the tubes within the chest are constricted and swollen, and it's hard to get lung out, that's asthma. Now, there is a relationship between true asthma and reflux. One of my colleagues showed that 70% or more of asthma attacks are caused by reflux and not by allergens. So reflux and asthma do go together, but most people who have asthma actually don't have it. In fact, in my practice, about 80% of people with asthma don't have asthma, and I'm talking about now at this point well over 1,000 people with asthma who don't have asthma. So the question is, do you have asthma or not? And so you have to recognize that. Read the article on choking. Everyone, please sign up for the blog. You put your email in, you get a topic. This week's topic was famotidine. Is it safe? I can't remember next week's topic. I don't think I've decided yet. But understand that I'm trying to keep this information available for you, for the people who watch this, and the people who do consultations. And if you're really in trouble and you're seeing 16 doctors, consider doing a consultation with me. You can click on that on the Jamie Koufman site, do a consultation. I want to talk about postnasal drip because this same asthma patient has a constant postnasal drip, and I want to talk about postnasal drip. So postnasal drip is not caused by allergies, okay? Allergies produce thin, watery stuff. It never gets on the vocal cords. It has to be moved. So thick mucus, it gets stuck places, and it's annoying, it causes chronic throat clearing. It's the number one and number two reflux symptoms there are, respiratory reflux. Well, let me just go over that term one more time. For those of you who are just getting your feet wet in LPR, laryngopharyngeal reflux, I made that term up in 1987 because I didn't want to say GERD for people who had reflux here. But the new term, respiratory reflux, is easier to pronounce, laryngopharyngeal reflux. And what about the sinuses? What about the breathing problems? What about, ears? All of these things. So the respiratory system can be affected by reflux. So the new term is respiratory reflux, and let the gastroenterologist have esophageal reflux, and the term GERD ought to disappear as an overarching term for anything. So Doug wants to know, does it erase all gains to build in a cheat day to acid reflux, 6 days on, 1 day off, 6 days on, 1 day off? Don't even bother with the 6 days on. So if you go out and you drink and you reflux all night, that's all you need is once a week to keep this going. So in fact, when I tell people doing 4-week detox, if you go out and cheat, you might as well start over again. It's not a detox. If you're, you go to rehab and you say, we just smoke a joint on Saturday night, which is party night. That's not how that's not how detox works. So there's no such thing. What you're doing is you're making some of your symptoms better. You're controlling to some extent your reflux symptoms, but you're not really treating your reflux. I want people to get better. You're going to get better, your symptoms are going to get better, your lifestyle is going to get better, and not only is your reflux going to get better, you're going to live to be a healthy old men and healthy old women. So, the cheating thing, in fact, I had a guy who was a New York City fireman who was very proud of himself when he came in after 3 weeks after his initial evaluation, and his reflux was twice as bad as it was. And he said, I'm doing the diet, but he was doing the diet except for Friday and Saturday night, where he was going out and tying one on, usually at a steakhouse or a place like that late. I'm over time, so I'm going to pick one more question. And I don't know the answer to this one. I will talk about it though. I have a question. Why sometimes I have an immediate reaction to something I eat or drink, and other times it may reach 12 hours later? Does this mean I have both LPR and GERD? No, it has nothing to do with GERD. So GERD is somewhere else. Reflux triggers come in at least 3 varieties. Variety number 1 is I used to eat chocolate and I'd be refluxing within 5 minutes. The theobromine, it makes the lower valve relax. For me, it was a bad trigger food. So that's one kind of trigger food. Second type of trigger food is if I eat red pepper, I cough. So there are vagal receptors that don't like that chemical. Finally, if I used to eat green peppers, I get reflux, but it's because my stomach didn't like green peppers, and I get a little gastroparesis and say, I'm not doing it, and I get reflux. Now, there's no question that some people get immediate or relatively quick reactions, and many people, they wake up the next morning and their reflux is much worse. They're coughing, they got hocking up more stuff than they were days before. They shouldn't have gone out to that steakhouse. But the reality is it's both, and I don't know why, and I don't know which why, and I don't know whether it's trigger foods or not. But both of those things can be related to reflux. So I want to thank you for listening today. Get me out there as much as you can. I'm old. I'm going to be 77 this year, and my work is important work, and I want to reach as many people as I can, as the medical establishment seems to be reluctant to change their patterns of behavior. Anyway, thank you very much.